Yes. Just sir.
Is
it visible?
No, can you put the slide, sir?
Yeah, slideshow. Yeah.
I is missing in your name, or it has come to the next sentence.
No, it's actually while in this mode it went like this one.
Change the font size, it will go back. Sorry, stretch the box. Yeah, stretch the box. Or delay. Yeah. Okay. You turn the power slides.
Yes.
Yeah. 2 minutes, you can start.
Right, sir. Once you tell me, I'll start. Yeah, right.
Can start, Chandresh.
Good morning, everybody. Today's topic is very interesting topic, management of traumatic brain injury. Actually, if you look at the data by Indian Head Injury Foundation, every year 10 lakh people suffer from serious head injury. And if you see out of this population, almost 60% of the people, they get this head injury because of the road traffic accident. And it has a serious complications, which we all know. And that's why this topic is very important to understand as an intensivist. If you look at the mode of injury, most of the young people, they get involved in these injuries because of the motor vehicle collision, and elderly population generally either fall from the height or some other injuries causing this kind of traumatic brain injury. So it encompasses a broad range of pathologic injuries to the brain of varying clinical severity that result from the head trauma. And if you look at out of 100% of these injuries, almost 50 to 60% of injuries, it is because of the motor vehicle accident. Maybe around 20 to 30% because of fall, which involves infant, children, elderly people. Because of the assault, also 9 to 10% people get in this kind of head injury. And sports and recreational activity also leading to traumatic brain injury is also common. Now, if you look at the definitions, head injury is different and traumatic brain injury is different. Head injury is a clinically evident when you do the physical examination, while many of the times by physical examination, you cannot make it that whether traumatic brain injury is there or not. So sometimes it might not be clinically evident. Now, if you classify head injury or traumatic brain injury specifically, it can be classified as a closed traumatic brain injury versus penetrating traumatic brain injury. It can be defined as a primary or secondary. It can be defined as a mild TBI, moderate TBI, severe TBI as per the GCS, or maybe as per the duration of loss of conscious level, or maybe the post-traumatic amnesia. Now, properly classifying this injury, we should really understand that what GCS will keep the patient in a severe traumatic brain injury. So if a GCS score is 3 to 8, these patients considered to have severe TBI, moderate 9 to 12, or mild is 13 to 15 GCS score. If you look at the loss of consciousness duration, if a patient after the trauma, if more than 6 hours patient is unconscious, then this can be considered as a severe traumatic brain injury. If a patient is having a post-traumatic amnesia for more than 7 days, this should be also considered as a severe traumatic brain injury. Now, all we know that there are 2 types of pathophysiologic mechanism involved in the brain injury. One is a primary, one is a secondary. Primary brain injury happens at the time of trauma. So it occurs at the time of trauma. Its common mechanism includes like either it can be because of direct heavy impact, because of rapid acceleration or deceleration penetrating injury, or blast waves. The damage that results includes a combination of focal contusion and hematomas, as well as shearing of white matter tracts along with the cerebral edema and swelling. But if you look at the secondary brain injury, generally it is because of a cascade of molecular injury mechanism, which involves neurotransmitter mediated excitotoxicity, causing glutamate free radical injury to the cell membrane, and electrolyte imbalance can also play a very important role. Mitochondrial dysfunction, inflammatory responses, apoptosis, secondary ischemia from vasospasm, focal microvascular occlusion, and vascular injury. These are the mechanisms which can lead to the secondary brain injury. And if you see the common reasons why a patient gets secondary brain injury is, they are hypotension, hypoxia, which can decrease the substrate delivery of the oxygen and glucose to the injured brain. Fever can also one of the major cause to cause the secondary brain injury, seizures, and hyperglycemia. And here the intensivist role is very important. A patient who comes with a traumatic brain injury might have only one component of primary traumatic brain injury. But once patient stays in the ICU, it is our duty that patient should not get any secondary brain injury iatrogenically. Now, one of the very important parameter is intracranial pressure when we talk about the traumatic brain injury. So let's understand the basic physiology about intracranial pressure. It is a normal ICP between the 5 to 13 mmHg. Now, as we all know, that skull is a very tight structure which is composed of brain, blood, and cerebrospinal fluid. Now, if there is an increase in one of the component, there will be automatically compensation by decrease in the other volume. And this hypothesis we know as a Monro-Kelly hypothesis. Now, this compensatory mechanism includes either the movement of CSF into the spinal sac, increased reuptake of CSF, or compression of venous sinuses. So we know this is the ICP elastance curve. As you see, the first stage and second stage where the compensation phase occurs, here the majority of the change in the volume will not increase ICP too much. But if you look at the stage 3 and 3, after a certain point where the end of phase of compensation happens, the drastically ICP will go up even with the slight change in the volume of the skull. Now, look at the physical changes with increased intracranial pressure. We should know that what we should monitor in the ICU. Suppose the patient who is already intubated, who is not having a proper consciousness, in those patients, our monitoring for the ICP should be more careful. And how to know that this patient is having an early sign of raised ICP or not? Look at the mental status parameter. If a patient is completely conscious but slowly the consciousness deteriorates, we should keep this in mind that patient can have a raised ICP. Looking at the pupillary size also, we can comment if there is a ipsilateral dilatation, like an isochoria is there, if reflexes are becoming sluggish, then also our suspicion for raised ICP should go up. Looking at the blood pressure which are earlier very within a normal limit, and all of a sudden you start observing systolic pressure going up and diastolic pressure going low, and there is a wide pulse pressure. Always in this kind of brain injury patient, you keep ICP in mind. Looking at the respiratory pattern also, a patient who is having a chain stroke respiratory pattern all of a sudden, and if a temperature is high, that time also your suspicion for raised ICP should go up. So what kind of intervention generally we do in this kind of situation? Yes, first of all, to prove the raised ICP, if there is a radiology imaging is possible immediately, you can go ahead with the CT scan, and depending on the patient's overall abnormal CT finding, surgeon can take a call of surgical intervention. And sometimes if a patient's ICP goes up drastically high, and if there is no time for even neuroimaging, sometimes patient can be taken directly to the operation theater for a decompressive craniectomy. Let's see, if such patient comes to you in ICU, how do you evaluate and how to go ahead with the treatment? So once, before even patient comes to ER, the care which they get in the transport, that is very important. That is called as the pre-hospital care. Actually, the primary goal of pre-hospital management of severe head injury is to prevent the hypotension and hypoxia, because both of these things can lead to secondary brain injury. The early endotracheal intubation is generally recommended for patients with GCS of 8 or less. That too, if it is performed by the well-trained personnel. Now, if this expertise is not available, even the bag and mask ventilation is also okay. Now, in one of the meta-analysis of clinical trials and population-based studies, they found that hypoxia and hypotension were present in almost 50 to 30% of the patients respectively, and they were each associated with a higher likelihood of poor outcomes. So the primary goal should be to avoid the hypotension, to avoid the hypoxia in a pre-hospital setup. Now, if you see, how do you deal with the hypotension if you found the patient before even arrival to ER? The first choice of the fluid should be isotonic crystalloid. Here, the studies of hypertonic saline in a pre-hospital settings have not suggested a benefit. And still, if you look at the fluid of choice, the saline is preferred over albumin, because you know that albumin has an increased mortality in one of the randomized studies of the patient with the TBI. Now, patient with TBI should be assumed to have a spinal fracture also in mind, and that's why the cervical fixation or cervical stabilization, in fact, it's very important. So while transporting this patient, a patient should have a cervical collar in situ until you exclude with the help of CT or any other imaging. Now, precautions taken to stabilize and immobilize the spine during the transport is very much essential. Now, once the patient comes to ER, our assessment is done according to the ATLS protocol. So always look for the adequate oxygenation. The blood pressure support should be initially started. If you think that even after the saline bolus, if patient systolic BP is less than 90, the next choice should be a vasopressor, minimal support of NORAD support to maintain the MAP. Now, vital signs including the heart rate, blood pressure, respiratory rate, these are very important. And a neurological examination should be completed as soon as possible, because the neurological status should be continuously assessed, and deterioration is common in the initial hours after the injury, particularly even while patient is getting an initial stabilization in ER, the neurological deterioration is possible. So the careful observation is very important. Now, coming to neuroimaging, which modality is preferred in a traumatic brain injury? So definitely the non-contrast computed tomography, CT, is the preferred imaging modality in the acute phase of head trauma. It should be performed as quickly as possible. And you know that all the CT scan can detect the skull fractures, intracranial hematoma, and cerebral edema, and all these components of traumatic brain injury. Now, how do you select the adult patient, and how do you suggest them CT scan? The guideline published by the NICE and Royal College of Surgeons, it really helps us to select the patients who comes with the traumatic brain injury or suspected traumatic brain injury who requires CT scan. Now, GCS less than 13 or on initial assessment in ER department should go for the CT. If a patient is having a GCS less than 15 at 2 hours after the injury in the ER, then also you should go for the CT. The suspected open and depressed skull fracture or any sign of basal skull fracture, like a sign like a hemotympanum, panda eyes, or betel sign, if it is visible, your suspicion of traumatic brain injury should be there, and patient should go for the non-contrast CT of brain. Now, other few indications, if your patient is having any seizure activity after the trauma, if patient is having any focal neurological deficit, more than one episode of vomiting, and amnesia for events more than 30 minutes before the impact. Now, this kind of patient, if there is also some loss of consciousness or amnesia since the injury with at least one of the following: if patient is elderly, like more than 65 years or older, if patient is having any history of coagulopathy, bleeding, clotting disorder, or if patient is on some kind of anticoagulant like warfarin, a patient who met with an accident with a dangerous mechanism of injury, like a pedestrian or cyclist hit by a motor vehicle, or a patient who was occupant and ejected from the motor vehicle, or a fall from the height of greater than 1 meter or 5 stairs. These all patients should go for the non-contrast CT scan as a primary investigation tool. Now, look at the ICP monitoring, which is very important in all the traumatic brain injury patient. It is appropriate in a severe head injury patient with an abnormal CT. Or if a patient is normal CT scan, if patient is having a normal CT scan, but if one of the parameter, or sorry, two or more parameters are noted in the admission, your ICP monitoring should come into the picture. If systolic BP is less than 90, if age is more than 40 years, or if there is a uni or bilateral motor posturing is available, then your ICP monitoring should start. Now, how do you monitor the ICP? There are different methods of ICP monitoring, but one of the most common method is a ventricular catheter. So it is connected to the external strain gauge, and it is generally the most accurate, low cost and reliable method to monitor the ICP. It also allows to draw the CSF, and by this way, you can actually do the therapeutic CSF drainage. There is another modality where you do the ICP transduction via the fiber optic or strain gauge devices placed in the ventricular catheter, which can provide similar benefits, but at a higher cost. Now, you all know these curves. These are called ICP waves. P1 is equal to is called percussion wave. P2 is tidal wave, and P3 is dichrotic wave. The normal compliance of the brain will reflect as this kind of P1 predominant pattern wave. But if you see the dominance of P2 goes up, if the tidal volume, if it goes, tidal wave is going up, it means it is a poor compliance or the reduced compliance as per the IC wave is concerned. Now, the other modality to see the ICP or to monitor the ICP is ultrasonography. How? So, indirect way to look at the ICP is looking at the optic nerve sheath diameter. We, being intensivist, generally ultrasound very accessible in the ICU, and it is one of the modality even before jumping to the CT scan. While assessing the patients with the traumatic brain injury, you can use this tool. Increased optic nerve sheath diameter, it always correlates with increased ICP, but you should remember the limits. The upper limit for the normal optic nerve sheath diameter vary with the age. Suppose if an adult patient is there, your optic nerve sheath diameter will be always less than 5 mm. If it is more than 5 mm, it means there is a evidence of elevated ICP. If there are children, if infants are there, maybe the less than 4 mm, but if children more than 1 year, you should consider 4.5 mm as an upper limit. And what about the optic nerve sheath diameter, which is more than 5 mm? It indicates always ICP can be more than 20 mmHg. So how do you do this optic nerve sheath diameter test at bedside? Generally, you can use the linear probe for this assessment, but where exactly you have to take this measurement? For that, you have to find the ocular globe and decide where is the exactly retina located. Exactly behind the retina, you should keep the distance of 0.3 centimeter, and then you should take the diameter. So here, if you see the distance between 2A point is 0.33 centimeter, which is the exactly level where we should check the optic nerve sheath diameter. And here between 2B point, it shows around 0.35 centimeter, which is normally within normal limit in adult patient. Now, how do you deal with elevated intracranial pressure? definitely you know that it is associated with increased mortality and worsened outcome. The efforts to evaluate and manage the increased ICP should begin immediately in the emergency department. Now, patient with TBI whose DCS is less than 8 and clinical symptoms which suggest the possible impending herniation from high ICP can be unilateral or bilateral fixed and dilated pupils. Patient can start showing the decorticate movement or decerebral posturing. Patient can have sudden bradycardia and hypertension, and patient can also have the respiratory depression. These are all the impending signs of herniation, and it should be treated urgently. Now, what are the simple technique which you can initiate in the ER itself? Initially, head of bed elevation to 30 degree. Definitely, it will help in optimization of venous drainage by keeping the neck in the neutral position or by loosening the neck braces if it is too tight because of the ET tube secure. You should loosen it. So, with these simple techniques, you can actually start reducing the ICP. Now, hyperventilation. Trauma guidelines recommend avoiding the hyperventilation, especially in the acute phase within 24 or 48 hours, because in this time, normally the hemodynamics might not be normal. A patient can have a borderline blood pressure. Now, mild to moderate hyperventilation can be considered at a later stage, but PaCO2 should not be less than 30 mmHg, which we should take care. Now, another way to reduce the ICP is osmotic therapy. And this is very important intervention what we see in the ICU. The intravascular injection of any hyperosmolar agents create an osmolar gradient, and that's why it helps drawing water across the blood-brain barrier. The most common two solutions which we use for the osmotic therapy is mannitol and hypertonic saline. A mannitol is administered in a boluses of 0.25 to 1 mg per kg, and monitoring of serum osmolarity, fluid balance, and renal function is very important while giving the osmotic therapy. Now, if you look at the hypertonic saline, it comes in a various concentration, starts from 3% to 23.4%, and this can be given either as a bolus or as a continuous infusion. Now, if you look at this is the topic of debate. Which one is better? Like hyperosmolar therapy, if you want to start mannitol or hypertonic saline, both has their own advantages and disadvantages. Now, if you look at the individual property, the mannitol, which increases the gradient across the blood-brain barrier, it reduces the ICP rapidly, and the duration of effect is up to 6 hours. While hypertonic saline, the duration effect is up to 4 hours, and it also reduces ICP immediately. But if you see other additional characteristic of these two fluid, mannitol can cause cerebral vasoconstriction. It can decrease the blood viscosity. It can also increase the cerebral blood flow. While hypertonic saline has an additional mixed immunomodulatory and anti-inflammatory effect. So, as far as the hemodynamics are concerned, if a patient who comes with a trauma with hypovolemia, and if you put them on mannitol, then definitely the next thing will happen, which is hypovolemia and hypotension, which will again detrimental to the brain. In that way, if a patient who is having a hemodynamic instability, better to avoid mannitol and go ahead with the hypertonic saline. Yes, even hypertonic saline can cause an increase in the intravascular volume, which can definitely it can lead to pulmonary edema as well. A patient who is having a poor cardiac reserve, they can have pulmonary edema. So while using these two fluids, be careful about the hemodynamics effect of these two fluids. Now, if you look at the rebound or recurrent edema, this can happen more with the mannitol, because mannitol is having a reflection coefficient of 0.9, which means it is mostly impermeable, but not absolutely. While hypertonic saline, which is having a reflection coefficient of 1, it means it is completely impermeable, assuming the intact blood-brain barrier. Now, various studies started from 2003 till 2015, which had showed that there is no much difference in mortality or neurological improvement as far as these two fluids are concerned. One of the study in 2015, it has told that definitely hypertonic saline provide lower daily and cumulative increased ICP and shorter period of ICU. Otherwise, majority of the studies, they showed there is no significant difference in choosing these two fluids. But at the same time, along with the traumatic brain injury, these fluids has been studied in the stroke or in SH also, where few of the papers or study, they have told that hypertonic saline is more used in their ICU because it has helped in reducing ICP better. There are few adverse effects also by using hyperosmolar therapy. Those are central pontine myelinosis, electrolyte disturbances, volume overload can happen. A patient can have renal insufficiency, phlebitis, and local tissue damage, and rebound increase in ICP, which is more common in mannitol. Another one modality to reduce the ICP is sedation, and which is also very important clinical aspect. Now, the use of sedative medications and pharmacological paralysis are often used in patients with severe head injury and elevated ICP. Sedation may lower the ICP by reducing the metabolic demand. You should know about the barbiturated coma, which has been used traditionally in this setting, but there is a little clinical data to support its use. One of the study which studied almost 73 patients in severe traumatic brain injury, there they concluded that phenobarbital coma was associated with more effective ICP control compared to the control treatment, but it has not improved 30-day mortality. That's why if you look at the ICP management tiers like tier 1, tier 2, and tier 3, the barbiturated coma comes as a last resort. Now, cerebral perfusion pressure is one of the parameters which we should be keeping in mind. The cerebral autoregulation is disrupted in about one-third of the patients with severe traumatic brain injury. The patient with impaired cerebral autoregulation, they are described as pressure passive. So the difference between the mean arterial pressure and ICP is equal to cerebral pressure, perfusion pressure. Now this CPP target should be around 60, and we should always make sure that CPP should not go more than 70 and it should not be less than 50. So it is achieved by the optimizing ICP first and then mean arterial pressure second. Temperature is also very important parameter which we should look into. Like fever worsens the outcome. Induced hypothermia has been proposed treatment for TBI based upon its potential to reduce ICP as well as to provide the neuroprotection and prevent the secondary brain injury. This induced hypothermia has been shown to be effective in improving neurological outcome after the ventricular fibrillation cardiac arrest. So again, if you look at the ICP management tier approach, this therapeutic hypothermia comes as a third tier of ICP management. A systematic review of 12 randomized RCTs has been studied, and they noted that small but significant decrease in the risk of death or poor neurological outcomes among the more than 500 patients treated with the hypothermia. So the borderline benefits for death and neurological outcome, as well as an increased risk of pneumonia in the patient who got treated with the therapeutic hypothermia. And that's why it should be limited to only to the clinical trials. Even the fourth edition of BTF guideline does not recommend therapeutic hypothermia as a prophylactic tool. Role of glucocorticoids. Again, the effect of glucocorticoids on blood-brain barrier, on the cellular edema, as we all know. But here in traumatic brain injury, the use of glucocorticoid therapy following the head trauma, it was found to be harmful rather than beneficial. One of the trial which has studied this effect is a CRASH trial. And we all know that corticosteroid randomization after the significant head injury has showed the harmful effect after the traumatic brain injury. Remember this trial, CRASH trial. Now, refractory intracranial hypertension, how should be treated? It should be treated with the hyperventilation, barbiturated coma, induced hypothermia, and at last decompressive craniectomy. So initial interventions, whatever we do to reduce the ICP, if with that also if patient's ICP is not getting reduced, one of these treatment option can be considered. The hyperventilation should be avoided in first 24 to 48 hours, as I told earlier, and it should not exceed PaCO2 less than 30 mmHg. Now, role of antibiotics in traumatic brain injury. Definitely, it is not recommended in a patient with a traumatic brain injury. But if you see that if a patient is having a penetrating head injury, if a patient is having an open skull fracture, or there is a complicated scalp laceration, we may still consider antibiotic prophylaxis. Now, coming to venous thromboembolism prophylaxis. Yes, most of the patient with a traumatic brain injury will be immobile. Either they will be on ventilator support, or because of the poor neurological condition, they might be bed confined. So the chances of venous thromboembolism is very high. And to prevent that, you can use either intermittent pneumatic compression stockings, or if patient's traumatic brain injury component is not so severe, you can still consider antithrombotic therapy. But here again, it should be weighted against the potential risk of hemorrhage, generally, which is very high in first 2 days. Now, coming to glucose management. So hyperglycemia and hypoglycemia both can lead to secondary brain injury. And that's why one of the proper study of glucose management in 77 patients with a severe traumatic brain injury has shown that hyperglycemia, if sugar level is more than 170, it is an independent predictor of poor GCS. So what should be the target of blood glucose? It should be maintained between 140 to 180 mg/dl. Now, hemostatic therapy and nutritional support in a patient with a TBI, the coagulopathy should be corrected to maintain an INR of less than 1.4, and platelet count should be more than 75,000. And looking at the nutritional support, the feed should begin in the first 72 hours to attain the full caloric replacement by post-injury day 7. So the target of full caloric replacement should be by 7th day. How do you prevent the seizures? So anticonvulsants are recommended to decrease the incidence of early seizures. Early seizures generally labeled as the seizures which occurs within 7 days of injury. And the prophylactic use of phenytoin or valproate to prevent the onset of late post-traumatic seizures is not recommended at all. Now, if you see, all the traumatic brain injury component patient might not require seizure prophylaxis, but a patient with a depressed skull fracture, patient who is already paralyzed and intubated patient, seizure at the time of injury, if a patient is having a penetrating brain injury, if a patient is having a SDH or EDH or IC bleed, these all are the indications where you can start the acute seizure prophylaxis. Here also, again, the choice of anti-epileptic agent, either levetiracetam or phenytoin. So you should understand that these drugs generally are routinely used in ICU, but the preference can be given to either phenytoin or levetiracetam. Now the thing is, simple dosing is very easy with a Levipil, while the drug level monitoring is very important in a phenytoin. That's why I think Levipil is a more suitable option nowadays. Looking at the different threshold in traumatic brain injury patients, if it is about blood pressure threshold, always maintain systolic BP more than 100 mmHg if a patient is between 50 to 70 year old. But otherwise, in most of the patient, our target should be more than 110 mmHg of pressure, systolic blood pressure. If it is about ICP, always remember more than 22 mmHg should have immediately intervention, surgical intervention, and definitely this kind of higher ICP is associated with a higher mortality. If you look at the cerebral perfusion pressure, as I told earlier, it should be between 60 to 70 mmHg. And if you are using advanced cerebral monitoring threshold, then your jugular venous saturation should not be less than 50. Now, surgical treatment is a very important aspect of treating this traumatic brain injury. Now, different traumatic brain injury component have a different threshold. If you look at the acute SDH, when do you opt for neurological intervention? If SDH thickness is 1 centimeter, or if there is a midline shift of 0.5 centimeter. Now, any size of SDH which declines the GCS more than 2 points, then definitely this patient should go for surgical intervention. If it is about extradural hemorrhage, you can measure the volume. If volume is more than 30 centimeter, if the thickness is more than 15 mm, if the midline shift is more than 5 mm, or if GCS is less than or equal to 8, the patient should go for a surgical intervention. If it is about contusions, if a patient is comatose and who is having a brain hemorrhage which cause the midline shift of more than 5 mm, or if there is an impending sign of herniation, patient should go for the neurosurgery. If cerebral hemorrhage happens, we should see here mass effect, brain stem compression, or hydrocephalus, which can be evident on CT scan finding. Then patient should go for the surgical intervention. If a patient is having any open fractures, depressed greater than the thickness of the cranium, this kind of depressed skull fracture should be taken care by surgery. Now, decompressive craniotomy is the main surgery which we perform for the traumatic brain injury patient. Now here the substantial portion of the skull is removed in order to reduce the ICP. It can be done in a combination with the evacuation procedure, or it can be done as a primary treatment for the increased ICP as well. The large fronto-temporoparietal decompressive craniectomy, which should not be not less than 12 by 15 centimeter, is recommended over a small frontotemporal decompressive craniectomy. Now, earlier, bifrontal decompressive craniotomy was done, but now it is not recommended to improve the outcomes, because the 6 months outcome, like Glasgow outcome scale, it has shown that patient with bifrontal decompressive craniotomy, they end up into vegetative status, though mortality benefit can be there, but the quality of life can be poor. And the two very popular trials, DECRA trial and rescue ICP trial, has given proper evidence that the survival with decompressive craniectomy is high. At the same time, they have already also mentioned that patient can have a poor quality of life, patient can be vegetative also. So still, in a raised ICP, when a patient is having an early sign of herniation, or the decompressive craniotomy is the first choice. How do you monitor these patients if the patient, these patients comes even after the surgery or before shifting to OT? So generally, we can categorize this neuromonitoring in 3 parameters, like functional status, substrate delivery, or biomarker. We can examine the patient, and as per the neurological functions, we can categorize them. If we have a modality like EEG and evoke potential, if a patient who is having a invasive neuromonitoring system in place, that can also help us to take a decision whether this patient requires any early emergency neurological intervention or not. Sometimes even the biomarkers can tell us about the severity of injury. We'll see how the non-invasive modalities helping to the neuromonitoring of this patient. Doppler, optic nerve sheath diameter, neuroimaging, and tympanic placement, these all comes as a non-invasive tools. If you look at the transcranial Doppler, it is one of the non-invasive and most commonly used method at bedside. Direct measurement of blood flow in the brain arteries can be seen. A flow velocity can be measured. It also allows the real-time detection of changes in the blood flow, and relatively it is very less expensive. It can be repeated frequently, and it can be used continuously also. It combines the ultrasound principle to present the erythrocyte flow in the basal cerebral arteries. Now, transcranial Doppler is often used to monitor the time course of the vasospasm after the subarachnoid hemorrhage. So, majority of the time, when our suspicion is vasospasm is high, this modality can be helpful. The interpretation of pulsatility index, which is also known as the Gosling index. What is the pulsatility index? It is the difference between the maximum and minimum blood flow. And it depends not only on the cerebrovascular resistance, but also on the several systemic and cerebral variables. This tool assesses the cerebrovascular autoregulation in TBI, also as well as in subarachnoid hemorrhage. There are different windows which we can use. The most common 4 windows. One is a suboccipital, temporal, transorbital, and low angle window, jaw angle window. So these are the windows from where you can look at the different arteries of the brain, and by measuring the velocity, actually you can decide whether there is a spasm component is there or not. If you want to remember, there are a few windows where particular flow velocity has been studied. If you look at from the orbital window, and if you see that ophthalmic artery flow velocity is less 20, if temporal middle cerebral artery is 55, These parameters will be helpful to suspect the vasospasm. At the same time, whether it is a mild, moderate, or severe, we can decide based on this flow velocity. If any point of time, if your flow velocity is more than 200 centimeter per second, then definitely this can be considered as a severe vasospasm. The Lindegaard ratio is also very helpful. How do you calculate this ratio? It is nothing but mean velocity of middle cerebral artery divided by mean velocity of internal carotid artery. The value which you get it can be considered as a Lindegaard ratio. If it is more than 6, consider that there can be a possibility of severe vasospasm. So now coming to the next modality, which can be considered as a cerebral microcirculation assessment. This play a very key role in the pathogenesis of organ dysfunction. Now, brain endothelial cells help regulate vessel diameter and permeability, and it can contribute to coupling of flow to metabolism. There are two modalities which we can use. One is a side stream dark field imaging, and another is intravital microscopy. These are very advanced tools. If you look at the oxygen monitoring in the brain tissue, there are another 3 modalities which we can use. One is a jugular venous bulb oximetry. Another one is a direct brain tissue oxygen measurement and near infrared spectroscopy. Coming to jugular venous bulb oximetry, this placement of the catheter into the jugular bulb and obtaining the oxygen saturation, it can indirectly estimate the cerebral oxygen consumption. So now it can be used as a global measure of adequate perfusion. It can be performed by intermittent sampling, or it can be used continuously also. The jugular oxygen saturation in a patient without the brain damage should be more than 57. Now, direct brain tissue oxygen pressure measurement, it is again one of the common technique which we can use in ICU. The marker, it is a marker of the balance between the regional oxygen supply and cellular oxygen consumption. The probe positioning is very crucial. Usually it can be inserted in the white matter. It provides a reasonable estimate of global brain oxygenation. If you look at the two numbers, the less than 20 mmHg of brain tissue oxygen pressure, it is worth treating. While if it is less than 15 mmHg only, then we can consider there is already brain hypoxia or ischemia is present. Coming to near infrared spectroscopy, the principle here, the oxyhemoglobin, deoxyhemoglobin, oxidase, cytochrome oxidase, they all absorb the specific portion of the light spectra. And the attenuation of the light signal is correlated to the relative proportion of oxyhemoglobin and deoxyhemoglobin and oxidase, cytochrome oxidase in the tissue. It is non-invasive and it can be used as a continuous monitor. Coming to the cerebral microdialysis, it involves the insertion of a catheter tipped with a semi-permeable membrane in the brain parenchyma. The CMT catheter is constantly perfused and thereby allowing the regular sampling of the patient's brain extracellular fluid. The CMD sampling is limited to the interstitial tissue there around the catheter, just measuring the regional brain metabolism. The elevated lactate pyruvate ratio and low glucose is considered as a warning sign of cerebral ischemia or hypoxia. The high lactate pyruvate ratio in the normoxemic conditions, it can be considered as a marker of hyperglycolysis, and the elevated glutamate is also a marker of cellular dysfunction. Coming to electrophysiological monitoring, it can be done by either EEG, by the bispectral monitoring, by the EVAC potential. If you see, the most commonly used tool in the ICU can be considered EEG. EEG can be helpful in evaluation of the spontaneous electrical activity in the brain, which can be used to guide the seizure management. It can also help us to assess the level of conscious level. It can detect the cerebral ischemia, and it can also help in monitoring the effects of medication. Now, intensivists must know few common patterns of the EEG like burst suppression, status epilepticus, brain death. If there is a burst suppression, it can be noticed in the anoxic brain injury, prolonged resuscitation, or if a patient is having a phenobarbital coma. So, looking at the pattern, the normal ECG, status epileptic ECG, burst suppression, how it will look, and if a patient is having any waves, considering brain death, these are the common EEG pictures, which you should remember. Now, advanced technology also has been used in treating the patient with a TBI, and one of the modalities TBI biomarkers. Whenever there is a traumatic brain injury, the changes are also happening at the cellular level. Either the glial cell get injured, either the patient's axonal injury is there. There can be inflammation after the injury, or patient's neurological cell injury is also possible. So there are different biomarkers have been studied, like neuron specific knowledge, glial fibrillary acidic protein, a patient with tau protein. So these biomarkers sometimes help to assess the severity of traumatic brain injury. Now, how do you prognosticate these patients? The prognosis in TBI can be considered based on the few indicators. Now, early indicators which can decide the prognosis, they are Glasgow Coma Scale. If a poor GCS at the time of arrival can again indicate the poor prognosis. Elderly patient can have a poor prognosis. A patient who is having an anisocoria and a patient who is having a loss of light reflex on arrival, those patients can have a poor prognosis. Patient who is having a hypotension, whose systolic blood pressure is less than 90 mmHg on arrival in ER, they can have a poor prognosis. A CT scan finding with midline shift of more than 5 mmHg also can indicate poor prognosis in a traumatic brain injury. So, if we summarize the entire trauma guidelines, particularly BTF guidelines 4th edition, we can summarize into few basic points, like prophylactic hypothermia is not recommended. Hypertonic saline versus monindol, there is still insufficient evidence to support use of a specific hyperosmolar agent. You should always remember the hyperventilation should be avoided in first 24 hours. It should be used as a immediate impending herniation situation. High dose barbiturate only for the refractory raised ICP. There is no role for steroid and prophylactic antibiotic in a traumatic brain injury patient. Phenytoin, yes, we can use to prevent early post-traumatic seizures. ICP more than 10 mmHg, we should always treat immediately. A target systolic blood pressure of more than 110 mmHg should be our target while treating the patient with traumatic brain injury. With this, I'll conclude this session. Thank you. Thank you all.
Okay. Are you able to hear me, Chandresh?
Yes, sir. I'm able to hear, sir.
Yes,
Yeah, yeah, you want to add something, Ghanshyam?
Thank you, Chandresh. I think you have kind of covered major aspects of management of traumatic brain injury. Just a couple of points. See, most of the time when we talk about traumatic brain injury, we try to focus on the immediate or the acute aspects of TBI management. But what we need to understand and remember is that these patients are going to stay with you for a long period of time. And don't write them off, because we have seen over the last many years that many patients who came with poor GCS, with continued support, good intensive care, rehabilitation, many of them get back to their decent quality of life. So it's not only the acute management, but it is also the long-term management, which makes a huge difference to these patients, especially in the later stages where they are prone for hospital-acquired infections, pressure sores, DVT, muscle weakness, contractures. These things are something which are very, very important in the management. Most of us don't kind of talk about this, but they are inseparable part of managing any traumatic brain injury patient.
Thank you, Ghanshyam. I think it's been a comprehensive, crisp review of traumatic brain injury. Only 2 or 3 points I would like to add. Ghanshyam did mention about DVT prophylaxis in these patients. It is always a debate whether a traumatic brain injury patient should get pharmacoprophylaxis or not. It is understood that lower the GCS, higher the chances of the patient developing DVT. This is an accepted norm or accepted thinking. So there is no way that a patient with traumatic brain injury should not get DVT prophylaxis. The basic that you can always do is to give them a mechanical prophylaxis with a sequential compression device. It is not the dead stockings, remember, it is the sequential compression device which you should be using. But majority of these patients who do not have an axial bleed like an extradural or a subdural hematoma are also candidates for pharmacoprophylaxis. Once the EDH is drained and the SDH is drained based on the drain performance and the surgeon's perspective, within 24 hours, you should always ask yourself whether pharmacoprophylaxis can be initiated. Second point I would like to make is, like all other organ injuries, like AKI and lung injury, traumatic brain injury also triggers a systemic inflammatory response. So these patients are febrile, these patients are tachycardic, but more often they drop their platelets on day 4 or day 5. And if there is an axial bleed like an EDH that has been evacuated or an SDH that has been evacuated, you should always attempt to keep the platelets around 1 lakh. This is something which is different from what we do in the general population. The last thing I would like to add is the whole paradigm of management of ICP and CPP of patients with traumatic brain injury has changed with the increasing availability of cerebral microdialysis. So you have to monitor the CPP and the partial brain oxygen, the partial pressure of brain tissue oxygen. So there will be 4 subsets of patients in whom both the PbTO2 and CPP are normal, where you only need to avoid secondary injuries like what Chandresh described. There are patients who have an abnormal PbTO2 but will have a normal CPP, where you have to optimize your ventilatory strategies to ensure that the oxygen extraction ratio is not abnormal, where your SgVO2 may come into the picture. There may be some patients who will have a normal PbTO2 but will have an abnormal CPP. Those are patients who need an aggressive regulation of ICP with the help of vasopressors and with the help of other strategies which Chandresh has said. As Chandresh said, these are usually patients with trauma. So there usually is lung injury, either direct trauma or because of aspiration or because of hospital-acquired healthcare associated infective complications. So there may be patients who have an abnormal PbTO2 and an abnormal CPP. Here, you should consider all strategies to improve the oxygenation while carrying out all your strategies to maintain the CPP. The use of ECMO was considered to be dangerous in patients with traumatic brain injury, but again, in the absence of an absolute contraindication for anticoagulation, in patients where oxygenation is a challenge, ECMO-driven support for the injured brain also has been done. So that is the gist of the addition to what Chandresh has presented. Thank you, Chandresh. We will meet again next week with a new topic.